This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
She's a 70-year-old lady. Case of primary angle closure glaucoma with and patent iridotomy. The other eye also has received a prophylactic iridotomy. She also has pseudoexfoliation and hypermature cataract to deal with. So this is a challenging situation. The antechamber is also relatively shallow. It's about 2.22 mm. So the challenges to deal with this eye is pupil is moderately dilating. Now since there's pseudoexfoliation, I'm also concerned about the health of zonules. Number 3, I'm also wary about the health of the antercapsule because these hypermature cataracts, the capsule sometimes can be having some areas of calcified zones or fibrotic zones, which can make capsular access a bit of a challenge. And lastly, dealing with the nucleus. I'm not sure how hard the nucleus is because of the overlying opaque cortical material. So I really don't know the density of the nucleus. So here are my plan. Number 1 would be to safeguard the endothelium because we might have a dense nucleus and a shallow chamber. So I'm going to use a dispersive OVD to safeguard the endothelium. Number 2, deal with the pupil by using a pupil expansion device. I'm going to use the BHEX ring in this patient. And then care has to be taken while creating the rhexis. So if the rhexis is fine and the zonules are healthy, then I don't see any problem in managing the nucleus. So I'm going to decide whether I'm going to do a vertical chop or a horizontal chop once I see the nucleus. So that was it. These are the plans which are made. Let's see how things turn out. The side ports are made. The capsule is stained. The corneal endothelium is coated with dispersive OVD. Time to perform the main incision. Now this is a rigid pupil. Ideally, I have to stretch the pupil a little bit and then go in and place the BHEX device. But sometimes stretching these iris can make them a little bit floppy and also can induce a slightly bigger sphincterotomy tears. So I'm just going in with BHEX ring directly without pre-stretching them, and let's see how things turn out. This is the classical method which I place the BHEX ring. Always I go in and use my right side port, go in with the BHEX ring forceps. The first 2 pair of notches on the opposite quadrant are engaged to the pupil, followed by the second set of notches. The chamber is refilled, the hands are switched, and the last pair of notches are then placed in. So now we have a decent sized 5.5mm opening of the pupil, which should be good enough. The exact health of the antercapsule is known only once I touch the capsule and start tearing it. Using the forceps, I begin the tearing now. As I begin the tearing, I was relieved to know that zonules seem to be quite healthy. This looks to be quite a healthy capsule and a healthy zonules as well. The capsule is tearing quite easily, so it was a sort of a relief for me. Once the capsular access is done, now is the time to do the vertical chopping. The overlying epinucleus and cortex is first aspirated out. My previous video, I think if you have seen, it was about a similar case, but I had demonstrated a horizontal chop. But in this case, I'm going to demonstrate to you the vertical chop in this case. Even though this nucleus is mobile and there's very less epinucleus and cortical support which is there behind the nucleus, but definitely this nucleus is not as mobile as the one which I had shown in the previous video. But nevertheless, even for vertical chop, the principles are going to be the same. We need to have a firmer grip. For that, I'm going to create a small central trench by sculpting. Once I feel about 50% depth is reached, now is the time to go and bury the phaco tip into the substance of the nucleus, and then the vertical chop maneuver is done. Mind you, the chopper is directly in front of the tip, exactly just in front of the tip itself, and the chopper goes down vertically, whereas my right hand is just stable. The left hand goes down and then lateral separation maneuvers. So I have a first crack of the nucleus. The nucleus is gently rotated. The same principle, the phaco tip goes in and buries into the nucleus. The nucleus is gently tipped up a little bit. The vertical chopper goes down and then there is a lateral separation maneuver. Although there is no epinuclear support, the nucleus is relatively freely mobile, but even in such cases, if we can have a good grip by burying the tip into the substance of the nucleus, we can do a proper vertical chop as well without inducing much of a torque. The nucleus is carefully divided into 6 small pieces. The OVD is replenished into the eye. Time to emulsify each of these fragments. Each of these fragments is gently pulled out of the bag, and at the pupillary plane, these fragments are emulsified one by one. This is the last fragment which is emulsified, and now is the time to deal with the cortex. As we all know, this is a hypermature cataract and hardly any cortex is remaining. I just use some BSS to squeeze off the posterior capsule, try to flush it. The remaining cortex is dealt with. And now is the time to implant the lens. The bag is filled with OVD. The planned single-piece lens is gently maneuvered into the eye. The distal haptic goes in first, followed by the proximal haptic. Both the haptics have gone into the bag. Now before removing the OVD, time to get rid of the BHEX ring. Notches of the BHEX device are disengaged from the pupillary margin, and then it is held and pulled out. That's it. OVD both in front of the lens and behind the lens is aspirated out. Side ports are hydrated. That's it, the case is done. These are the first day post-op pictures. Cornea is clear and the patient is doing pretty fine. So we can also perform the vertical chop in a Morgagnian-like cataract. Although this was not so much mobile, but still, again, the key factors are to have a good grip on the nucleus. There's a good hold. Bury the tip sufficiently deep into the nucleus so that we have a good hold. And then obviously use a slightly sharper chopper. Place it directly in front of the tip. The chopper goes down vertically and then laterally. And once the first chop is achieved, rotate the nucleus and continue to do the same. So that was it, the art of vertical chopping in a Morgagnian cataract. Thank you for watching and hope you found this helpful.